We now request Dr. Vasiki ma'am, Associate Professor of Pathology, TIRUNELVELI Medical College, to honor our Medical Superintendent, sir. Please, ma'am and sir. Thank you, ma'am and sir. We request our Medical Superintendent, Dr. Balasubramanian, sir, to address the gathering. Please, sir.
Very pleasant morning. To begin with, let me congratulate the team Pathology, headed by our most sincere, dedicated professor of our college, Dr. Swaminathan, sir, to have this wonderful conference. As far as myself is concerned, I usually used to say, whenever you are going to a conference, learn, at the same time enjoy the conference. You interact with your friends, have a party once again. And one more thing, we are having a very pleasant, what is it, madam? In Kuttalam, we are having a very breezy and waterfall is there. If anybody is willing, please go and enjoy. Thank you.
Thank you, sir. Now we proceed for Savani release. We don't remember days, we remember moments. Sometimes, a short walk down the lane is all it takes to appreciate where you are today. The best thing about memories is making them and compiling them as a Savani. Now, we request Dean Sir to release the Savani. Please, sir. Thank you, everyone. We request Dr. John C. Ma'am, Associate Professor of Pathology, TIRUNELVELI Medical College, to honor the President, Tnpciapm, Professor Dr. Sandhya Sundaram Ma'am. Please, ma'am. Thank you, ma'am. We kindly request Dr. Sandhya Sundaram ma'am, President, Tamil Nadu Pondicherry Chapter, IAPM, to say a few words. Please, ma'am.
A very pleasant morning. Dignitaries on the dais, Dean Sir, Principal Sir, MS Sir, Secretary Tnpciapm, my teachers on the front row, and all my colleagues and students who are here. It is indeed a great honor and distinct pleasure to be here for Tapcon 2022. And it is a dream come true. I think Swami's dream has come true. He wanted the hall full. And I really congratulate the entire team, Swami and his entire team, who put up such an excellent show. It started yesterday and it has gone through, and he has been constantly updating us on what is happening. I think each and everything has been so carefully selected. And I'm so proud that Tnpciapm chapter is one of the oldest chapters and has always been a landmark for each of the other states to emulate. And this conference has been a long-awaited one. As you see, people started with bright colors. I think nothing can match an offline conference. And indeed, it is a pleasure to be here, to be a part of it. And I congratulate Swami and his team and the entire team of TIRUNELVELI Medical College, who's put up such a great show. I wish the conference all success. And I only say one line, which I always remember: excellence is converting ordinary things into extraordinary things. And I think that is what this conference is all about. Thank you once again. Have a great time.
Thank you, ma'am. We are grateful for your esteemed presence among us on this occasion, ma'am. May we now call upon Dr. G. Gayatri ma'am, Associate Professor of Pathology, Tirunelveli Medical College, to honor Professor Dr. Chandramauleshwari ma'am. Please ma'am. Thank you, ma'am. Now we request Secretary, Tamil Nadu Pondicherry Chapter, IAPM, Professor Dr. Chandramauleshwari ma'am, to share her thoughts. Please, ma'am.
So good morning, one and all. My pranams and respects to the dignitaries on the stage and off the stage. As the last speaker of this inaugural function, I don't have much to say because everything has already been said by the speakers before me. So I just take it upon myself to enlighten you as to how this conference came up. So when we decided that the yearly conference has to come up, Swami sir was the first one to volunteer. He said it has to be done in the banks of Tamiraparani and in the windy areas of Kutralam, and then only you will be able to get something into your head, some intellectual knowledge also will enter your heads. We agreed immediately. So it was spontaneous. The response was spontaneous. Like he offered spontaneously and we also agreed spontaneously. And after that came the meetings, which of course were on Zoom platform. Every week, every 15 days it started initially and then became to every week as the conference date closed in on us. So initially, like the apprehension was, will anybody come to Tirunelveli? Like, will we be able to get the masses, get the postgraduates to attend the conference? Now the answer is in front of all of our eyes. The hall is full, like how he wanted it to be. Only thing is, we never had any doubts on the team Tirunelveli's capabilities to attract the people from everywhere for the conference. So we were sure about it, but sir is now, I think, seeing it for himself, he being the organizing secretary. And then came the funding part. Of course, with the treasurer, Dr. Teleflo, I was sure that there is not going to be a problem, but she had to struggle a bit to pull in a little more resources because the funding part was also something which we had to be concerned about in the initial stages. And then, of course, she wanted somebody to help her out because in the busy schedule, like a family and of course all of us, we have our own jobs to take care of, isn't it? So she wanted somebody solid to support her. And then came the Kubera Kadavul, like how in Srinivasa Kalyanam, Kuberan simply like poured in the funds, no? Like he said, you don't worry, I am there to take care of the fund. And that was Dr. C. N. Srinivas for us. So thank you one and all for all the contributions which you people have made. And during the Zoom meetings, like I could see the headship and leadership of Dr. Swaminathan sir, who simply kept on saying, don't worry about anything, just come to Tirunelveli, I'll take care of everything. So there, though we were all in the Zoom platform, we could actually not see the baseline work of the ground force which was working in Tirunelveli. We could sense it by the words of Dr. Swaminathan sir, and I'm seeing it here personally now. So hats off, kudos for all the effort, and I definitely know that it's going to be a grand success. So far it has been a success and it will continue to be so till the Kutralam also gets over. Thank you. All the very best.
Thank you for your kind words, ma'am. No person was ever honored for what he received. Honor has been the reward for what he gave. As a mark of respect to the endless contributions, we would like to honor our former HODs of pathology, Tirunelveli Medical College, in this glorious occasion. We humbly request Dr. Kalaivani ma'am to come to the dais. We request our Dean, Dr. Ravichandran sir, to honor Dr. Kalaivani ma'am. Please, ma'am and sir. Thank you, sir and ma'am. We request our Vice Principal, Dr. Shantaraman sir, to honor Dr. Shivashankaran sir. To the dais. We request our Vice Principal, Dr. Shantaraman sir, to honor Dr. Paramasivam sir. Thank you, sir. We now request Dr. Siddhi ma'am to come to the dais. We request Dr. Balasubramanian sir to honor Dr. Siddhi ma'am. Please, sir. Thank you, sir and ma'am. Now we request Dr. Sandhya ma'am to honor Dr. Shantaraman sir. We request Thank you, everyone.
Now, we humbly request Dr. Jhansi Malla ma'am, Associate Professor of Pathology, to deliver the vote of thanks.
Good morning to one and all. On behalf of Tnpciapm and Department of Pathology, TIRUNELVELI Medical College, I feel privileged to propose vote of thanks on this special occasion. First of all, I thank the Tnpciapm office bearers for giving us opportunity to host the annual conference of Tnpciapm Tapcon 2020 at TIRUNELVELI Medical College. I thank our Dean Sir, VP Sir, Medical Superintendent Sir, and Tnpciapm office bearers for their constant guidance and support. I am very thankful to all the speakers, chairpersons, and delegates for coming here and for their best wishes on in this inaugural function. I am also thankful to all the organizers, volunteers, and sponsors who all stood as backbone to conduct the Tapcon 2020. Once again, thank you all. Thank you.
We thank all the dignitaries for gracing our occasion. Thank you, sir. Thank you, ma'am. Let's break for tea.
Respected and reverend seniors sitting here. So we'll move on towards myxoid tumors. That is another challenging part when we deal with soft tissue tumors with some entities, how we uncover them. So the parameters morphologically to analyze apart from the clinical and radiological scenario on histopathology are cellularity, vascularity, atypia, and mitotic figures, because you have lesions like myxomas that are almost very paucicellular towards something like a myxo-inflammatory fibroblastic sarcoma that will be more cellular. So like I mentioned, you have myxomas, nerve sheath myxomas, and cellular myxomas that are very myxoid-rich tumors. They are acellular. You have a very peculiar vascular pattern that I mentioned. You will see curvilinear pattern in myxofibrosarcomas, a swirling arcades of blood vessels in fibromyxoid sarcomas with a patchy collagenous two myxoid areas, and you will see predominantly myxoid areas with the thin-walled vessels and atypical cells in relatively more superficial in older patients myxofibrosarcomas, which can be from low to intermediate to high grade depending upon the number of mitotic figures, atypical cells, and pleomorphism. So then you will have tumors like myoepithelial tumors, which can be very myxoid rich, and therein you have to put in stains like epithelial markers A1, A3, and EMA. Either of the two has to be positive, along with co-expression of S100 or GFAP, just like you have in the salivary gland tumors. So that's how you can identify a myoepithelial tumor of soft tissues, and the differentials here will be extraskeletal myxoid chondrosarcomas or a myxoid variant of a liposarcoma, which will have your favorite chicken wire like vascular pattern. If you've seen chicken wire cages, you will see that vascular pattern, and by MIFs you will see more inflammatory component, more pleomorphic cells, relatively lesser mitotic figures paradoxically that you will see otherwise in a pleomorphic sarcoma with eosinophils. Maybe you will see pseudo-inclusions or pseudo-lipoblastic cells in more acral based or superficial sites in younger patients. So that's an example of a tumor which has myxoid areas, and if you see rhythmically, it has collagenous areas as well. And then you see more closely, it has more like collagen rosettes, as we call them, described by Weiss and Lane. And that's what is actually a low-grade fibromyxoid sarcoma, because you see paucity of mitotic figures. You see more of these, collagenous and myxoid areas alternately, and you see this arcades of blood vessels, which are like swirling pattern of blood vessels. In this tumor that has been called as Evans tumor, because Dr. Evans described it for the first time. It's a very interesting history, because the two cases that he diagnosed, one was fibromatosis and the other was fibroma, until they metastasized, and he came to know, he designated these tumors as sarcomas. They can be paradoxically low in mitosis. They might not show you mitosis. In contrast, you will see more mitosis in nodular fasciitis. But it's the behavior of the tumor that tells that this is a sarcoma, not a benign tumor or a fibromatosis, because fibromatosis doesn't metastasize. So that's to share with you our experience of these challenging cases of 18 LGFMS, and we're trying to explore the relationship to this other tumor which can come as a part of it. It's called sclerosing epithelial fibrosarcoma, described by Jean Meis and Lars Gunnar Kindblom as another entity, which is more epithelial morphology, more collagenous areas. If you've seen this tumor, you can see this variation that can happen. And why we want to identify the SCF tumor or the SCF areas, because they are relatively more aggressive. Even though they might show you less mitotic figures, they will behave more aggressively. And this is what I was meaning about this swirling pattern or arcades of blood vessels. And you see more collagenous areas, almost like, osteoid. But now you have a marker called SAT-B2, and this will be negative. What it will show is MUC4 positivity, which you see in low-grade fibromyxoid sarcomas and also sclerosing epithelioid fibrosarcomas. And that's one of the quiz cases I kept in IJPM. You can see this very myxoid areas. This was a very, case coming from our director. And we could see these very peculiar blood vessels branching and these myxoid areas with this more sort of epithelial or collagenous areas. And this is what I was meaning. You can use a stain called MUC4. It diffusely highlights the entire tumor and helps you to reinforce the diagnosis of LGFMS or sclerosing epithelial fibrosarcomas, in contrast to fibromatosis that will show you beta-catenin that I showed you in the initial part, and these are mutually exclusive markers. So this is what I was meaning about this chicken wire vasculature that you will see with these signet ring cell isolate cells, which are your favorite lipoblastic cells, because you generally know them as multivaculated in an ALT. But you will see this signet ring cell picture in this otherwise myxoid rich area with this chicken wire vasculature in myxoid liposarcomas. And every time you see a myxoid liposarcoma, you need to see if there is a round cell component, because if it's more than 10%, it upscales this intermediate to high-grade sarcoma, and they have more chances to go to unusual sites like paraspinal region and maybe brain metastasis. Now that's another example where you can see morphology helps in designating a tumor. You see this fibromyxoid tumor, which is cellular with these polygonal cells, relatively bland. And you see this bone shell at the periphery, and it's kind of ossifying towards the periphery, which might not always happen. And if I see a tumor like this, I just put in one stain called S100 to reinforce the diagnosis of an ossifying fibromyxoid tumor. Of course, now it has its own genetic signature as well. Coming to lipomatous tumors, the challenge is, whether it's a lipoma or an ALT, because whenever you have a large-sized tumor, more than 8 centimeters, in deeper locations, think more towards an ALT or a well-differentiated liposarcoma. You might not have your lipoblast in a well-differentiated liposarcoma, so that's not a criterion. Paradoxically, you might see, cells which are looking more like differentiated, and until you make your note of these atypical cells in the stroma, and maybe, you will see this silky collagen that I used to learn from Dr. Anthony Square at Memorial Sloan Kettering. So this silky collagen with these atypical cells, maybe not lipoblasts, is a time when you throw in this marker called MDM2, and it will highlight all these cells to help you reinforce the diagnosis of this ALT well-differentiated liposarcoma. You can step ahead for this MDM2 gene amplification. You can see multiple green signals in contrast to in single red. So there we are looking at the amplification of an MDM2 in a ALT or well-differentiated liposarcoma. So you can see a differentiated liposarcoma as an alipogenic zone generally. You will see well-differentiated especially in sites like retroperitoneum. Whenever you see a pleomorphic sarcoma in retroperitoneum, you might not see the differentiated fat areas. Again, you put in the same marker, MDM2, it highlights all the cells. In this particular case, it is a homologous part of the dedifferentiated spectrum of the dedifferentiated liposarcoma. So every tumor, a lot of tumors can come as a spectrum of the dedifferentiated component of a dedifferentiated liposarcoma. So we need to know. You see a pleomorphic tumor, you see inflammatory cells, make sure you're putting an MDM2 in sites like abdomen or retroperitoneum. Coming to this 50 years old gentleman with a thigh mass, very pleomorphic tumor. You see a lot of inflammatory cells and mitotic figures if you go on higher magnification. So we used to call these tumors as MFH, and now it's been seen by the works of Dr. Chris Fletcher, whom we know respectfully in the contributions in soft tissue tumors, that there are a lot of sarcomas which have pleomorphic cells, but actually we don't use the word MFH anymore. And I can share with you a couple of examples of these otherwise pleomorphic sarcomas which were diagnosed as MFH. And you can see this first case with this showing SMA positivity. It was a pleomorphic sarcoma showing myogenic myofibroblastic differentiation. And this was another pleomorphic sarcoma which showed this desmin and myogenin diffuse positivity. It's a pleomorphic rhabdomyosarcoma, kind of a, one of the worst tumors in soft tissues. And it's a bit of a controversial entity because whenever you see a pleomorphic rhabdo, you have to make sure that you're not missing on a dedifferentiated lipose, which can have pleomorphic rhabdomyoblastic component. And this was another pleomorphic sarcoma which showed co-expression of HCAL desmin. It was a pleomorphic leiomyosarcoma because leiomyosarcomas are another chemosensitive tumors. And this is one of the tumors that is actually, again, one of the worst, showing S100 positivity, a pleomorphic MPNST, which also showed co-expression of desmin and as a skeletal muscle differentiation called as a triton tumor. So you can see over the years from 30% to 5% the diagnosis of pleomorphic sarcoma, not otherwise specified old school MFH, is where we have reached. There was times when a left-right tumors used to be called as MFH, like a waste basket, not anymore. So we moved from morphology, we've embraced immunohistochemistry, gone towards molecular with RT-PCR genetics, EM taken its own time, not used too much anymore because of cost constraints. And now we have newer ways to predict. We furnish grade and stage as prognostic parameters in sarcomas, but now we have nomograms, where is an integration of the size, depth. So you can see what all parameters are important. And you have now circulator, or these are some of these prediction models that are being used in oncology care for sarcoma patients, where you can actually predict a 5-year or a 10-year survival based on these parameters for certain histologies, like you have fibrosarcomas, which is actually a vanishingly rare entity, or pleomorphic sarcomas, MPNST. So the problem with the clinical trials have been in sarcomas that they have not integrated all the morphological types, and it's difficult because there are more than 200 sarcomas. But nonetheless, these are the nomograms which are being found to be clinically useful. So now presently we have a pathology report that should integrate all these essential parameters, like the kind of specimen, resection, site, depth, size, because again all these parameters I've alluded have their own importance. Microscopy, it doesn't substitute for the grade and stage because they are all interrelated in some ways or the other. You need to furnish, I always tell the residents, mitotic counts are very important. Abnormal mitosis are very important because they tell about aneuploidy, or your tumor probably is pleomorphic, barring exceptions of AFH of superficial sites. So again, microscopically, the margins which you see grossly, LVI, if you are seeing again, they can be more aggressive, but you see mostly in carcinomas. And if you've employed any ancillary findings, keep a note of it. That helps to reinforce your diagnosis. I'd like to wind my talk with some takeaways and messages. The right approach to diagnosis of sarcomas is answering the key clinical questions that I mentioned. I see identification of tumors with certain specific therapies lined up, like round cell sarcomas, or maybe you have certain spindle cell sarcomas like synovial sarcomas or leiomyosarcomas, in contrast to their counterparts which might not be so chemosensitive. Morphology is always the time-tested parameter which helps us to make a choice of the right markers, be it immunohistochemistry or molecular, and this cannot be overemphasized. We need to employ an optimal set of markers for certain round cell tumors. I don't believe in these random panels of doing MIC2 in every round cell because it might not help you, So if you are seeing a tumor which is having this, I call this small blue or large pink cells in a pediatric patient, start with desmin, myogenin, and myodivin, and that's it. Because you can see synaptophysin coming rarely positive in an ARMS, and you might end up calling it as a neuroblastoma in head neck sites, and we've seen that. So you need to know your morphology guides you towards appropriate choice of markers, and you integrate everything together. Always invest on more sensitive and specific markers. Like I mentioned, there was a time we used to use like 12, 13 markers for ASPS, but now we use TFE3. Again, it is not perfectly specific because you've seen translocation-related RCCs as well. So it's in a context that you utilize a marker and make sure you're doing your validation and controls at all times, because a wrong, you might be right in interpretation, but the control hasn't worked. So you have to always work with your labs towards it. Specific biomarkers for future targeted therapies like c-KIT dog1. Again, c-KIT doesn't translate, the patient gets imatinib in a non-GIST scenario, because again CD117 can come positive in 117 tumors perhaps. So we use IHC in molecular in a context because it's a famous saying, a tool in the hand of a fool can be a fool. So we don't want to be fooled. We use this integrated approach of timeless clinical details, radiology, conventional pathology, essentially with IHC. It's just that we've integrated a new dimension of molecular pathology to call this as a more quadrangle approach towards diagnosis of sarcoma care. And I leave the postgraduates at this interesting case of this excision that happened in a young patient of this superficial tumor, which was mitotically high, and in MIB was like 15 to 20%, picking everybody. But actually, if you see these features of this myxoid areas, and tear apart kind of myxoid areas with these muciphages and maybe occasional giant cells, multinucleate, it actually is nodular fasciitis just to an SMA, and that's it about it. So if you see a superficial tumor which is freaking out but not growing more than 3 centimeters, don't miss out on this entity. So another resource that I can share with you is our grossing and reporting of soft tissue tumors that we work together across the country with all the experts. And if you can refer to all what I said in this IJC, and I have to thank our immunohistochemistry lab, my colleagues at Molecular with whom I work, our clinical colleagues in bone and soft tissue and pediatric, where we make these very active decisions about diagnosis and triaging cases for molecular techniques, and my mentor and friend Ulrich Vogel from Germany, with whom I learned the tips and tricks of utilizing molecular techniques towards diagnosis. Thank you very much, and I'll be happy to take questions.
Thank you, sir, for an excellent lecture and great conceptualization of the topic. Chairperson, Dr. A.V. Shanti ma'am, can now share her views.
I should really thank you on your excellent repertoire and the way you have discussed about soft tissue tumors. Can you hear me? Okay. Professor Sundaram told me that he really appreciated your talk. He's left because he had to do a surgical case. Dr. Reiki, I just want to tell you that soft tissue tumors is one area all of us know in pathology is very difficult to put in one sort of a PDF or whatever you may call it, and put it across to the students, right? And you've done a great job by going from the fundamentals and integrating histomorphology, IHC, molecular genetics. I think this is one area in pathology where knowledge gives rise to more knowledge, and every technique evolves into a newer technique with the aim of benefit to the patient as far as targeted therapy is concerned. And I think most postgraduates will now understand it's not the choice or like of many students I know, because when I was a postgraduate, I used to dread if I see a soft tissue tumor under the microscope. But later on, this is one area which is very enigmatic, challenging, and makes you have a working classification to come out with a diagnosis. I think you have done a great justice to that. Thank you so much for your wonderful talk.
Handle it. I think this is what gives us an opportunity to handle more complex, and I think that's what human mind is towards, handling more complex things. So I like that. Thank you. Thank you, ma'am.
Thank you, sir and ma'am. Now we request Dr. A.V. Shanti ma'am to give away the memento to Dr. Bharat Reiki, sir. Please, ma'am.
இது யூஸ் பண்ணிக்கோங்க. காலர் நீங்கள் இதை வச்சுக்கோங்க. எனக்கு இது இருக்கு, அது கூட்டிடுறேன். காலர்
Okay then. Lungs are a pair of spongy organs filling most of the thoracic cavity with an incredible total surface area of 750 square feet, roughly a third the size of a tennis court, remarkably economical, serving both as an intake valve for air and a smokestack for exhaust. That's lung. Now we proceed with our second topic of the day, scientific session on pulmonary pathology, recent trends by Dr S Shankar sir, Professor and Head of Department, Kottayam Medical College. We welcome you to the stage, sir.
We request Dr. K. Krishnamurthy sir, Professor and Head of Department, Thoracic Medicine, Tirunelveli Medical College to moderate the session. Dr. Krishnamurthy sir did MBBS in our college and PG in Madras Medical College. He has experience as UG teacher since 2004 and PG teacher since 2012. He has contributed as a chairperson at State Task Force, National Tuberculosis Elimination Program, Tamil Nadu. He has many publications in his name and is hardworking. We welcome you, sir.
Also, we have Dr. Untitled ma'am, retired professor and head of department, Kilpauk Medical College, to moderate the session. Madam did her post-graduation in MMC and completed PhD in pathology in MGR Medical University. She served as professor and HOD in Department of Pathology in Sri Muthukumaran Medical College, Mangadu. Madam is a consultant pathologist in Bilroth Hospital, Shinoy Nagar, Chennai. She has held the post of convener of state-level IAPM. Due to her perseverance, she received Best Teacher Award from Dr. MGR University. We're glad to have you here, ma'am. We request Dr. K. Krishnamurthy sir to introduce the guest speaker.
Good morning all. Good morning all. I thank the organizers for giving me this opportunity. First of all, I want to congratulate the organizers and for the grand success of the CME. So I am happy to introduce our guest speaker for this second session, Professor Dr. S Shankar. He is a proud alumnus of our own Tirunelveli Medical College. He has completed his UG during 1986. Then his postgraduate in pathology in Trivandrum Medical College during 1990. Since then, I think he has been involved in medical education department in all areas. He is having several accolades throughout the past 30 years. Currently, he is a professor in HOD Department of Pathology at Government Medical College, Kottayam, Kerala. And he is also having several accolades or stars behind him. Dean of Faculty of Allied Health Sciences in KUHS and qualified as an impanel assessor of NABH. He is a nodal officer for the Lab Medical College, Central Lab Medical College, Trivandrum, and examiners for several examinations, question centers, and so at present, I think, and now recently I got the information, now he is promoted as the principal of the Kottayam Medical College. Congratulations, sir. He has been a motivation for several students, postgraduates as undergraduates, and guided them in several theses. He is also having his own publications and presented in several conferences. He has been authors, he has been a resource person. So several things for great inspiration for young postgraduates. Thank you, sir. So I invite him to give this great talk in lung and pathology. Welcome, sir.
Hello, madam. You are there to guide me through this session. I am extremely happy, probably the happiest person in this crowd, for 3 reasons. One, I am standing in the college where I have studied. There is I remember an old Tamil movie, Pugunda Vida, Puranta Vida, right? So, 85 I completed. Now, 33 years I have been in Kerala, very adjacent. And this is not a Puranta Vida for me, it is a Pugunda Vida also because I frequent very often here. Thank you, Tamil Nadu chapter. Secondly, because probably I have presented for Tamil Nadu chapter more than for Kerala chapter. If the trophies sitting in my room speak to me, so somehow I am unable to leave the roots. Thirdly, I should say that yesterday I became the principal of Government Medical College, Kottayam. I'm into admin now. Is it going to be my last talk on pathology? I don't know. But let's pray that if NMC continues its blessing, we can continue doing our work in pathology. Because pathology is not a subject to me. It's not a science to me. It's not a passion to me. It's me. I am here because of pathology. Dear students and delegates, this is not an area for me. I honestly agree 100% that I know nothing of pulmonary pathology. But what I am good at is taking up challenges, as it was stated. So I thought I will take up some new topic and try my hand at it. And what motivated me to take pulmonary pathology is because of my clinicians in Kottayam Medical College. Probably one of the best thoracic departments in the country. It's a heart transplant unit we have, and the bizarre number of specimens and cases we have is mind-boggling. So I thought I should share some of that. I'm not an expert on that, but I thought I would share what I learned the last 1.5 years. Can you show this one? Okay. He showed the wrong button. Okay. This, you know that pulmonary pathology has undergone a lot of changes, but not as much as Dr. Reiki said as in soft tissue. Thank God for that. But when you start on a lecture on pulmonary pathology, I generally start, I'm basically a teacher like Alavandar madam. I start from the foundations. Little bit about normal, little bit about the artifacts. You should know about a little bit of what is confusing and then go into the real thing. And in pulmonary pathology, the neoplasm and the non-neoplasm are equally important. And postmortem is also quite important. So it has got a lot of areas to be covered. I don't know whether I can do justice to all that. The role of ILC is as confusing in pulmonary pathology as it is in soft tissue sarcoma. And the more number of things you put in the panel, the more confused it becomes. Finally, we say ILC is favoring dash and morphology favoring something else. And this targeted therapy, that is the most important thing in pulmonary pathology because many of the tumors are inoperable. So here comes to help the clinician to tackle the tumor. And there are thankfully very little new entities and redefined old entities or revisions. So that part I can pass easily. You know that lung is made up of bronchioles, alveolar sacs, 3 things, plus the supportive system, the pleura and the blood vessels. But the histology, I'll just refresh. That bronchus is a really complicated thing. It's got too many cells. It's got the respiratory epithelium, goblet cells, neuroendocrine cells. So now you can think of all the tumors which come out of this. It's got a good supportive smooth muscle which can become hyperplastic, neoplastic. It can have elastic fibers and collagen which in their differing areas, differing capacity of proliferation induces different diseases. It is xeromucinous glands which create the salivary gland tumors in the lung. It's got lymphoid tissue which produces the lymphomas in the lung. And the cartilaginous rings which produce nothing, thankfully. So this is the bronchus. You can see the cartilage ring. So that's how you identify a bronchus. Yes. The bronchioles may have a little bit of cartilage if they are very proximal. But how do you identify a bronchiole? It's by the accompanying artery. You see the twinning thing. So when you see like that, so remember that the arterial diseases of the kidney, the lung, are going to affect the bronchioles. For example, your pulmonary hypertension. The alveoli, 3 cells only. Pneumocytes of 2 types, and the macrophages, nothing else. The others are connective tissue. So look at this, very easy, it's a very empty looking slide with only two types of cells, and you may find one flat and one tall, the flat one and tall one, the type 1 and type 2 pneumocyte and the macrophage. And the arteries, you know, various types of arteries are there, because the big ones will have the elastic laminas. Veins in the lungs have one elastic lamina. So whenever you see elastic lamina, don't think it's always an artery. And all of these can create a lot of confusing issues in your slides. And pleura, you will see here in the pleura. The pleura is a very simple structure with one mesothelium and a supportive tissue. But it is most confusing, creates lots of confusions, especially for cytologists. It may shed some cells, may not shed some cells. We will see that down the way. So roughly I think I spent about 3-4 minutes for the histology. I hope I didn't bore you. Other than histology, what's going to confuse us is the artifacts. Now the crush artifact, is it a bone or a vein? We diagnose small cell carcinoma by the crush artifact. But if it occurs in the squamous epithelium, it will confuse you. So it's both a vein and a bone. The hemorrhage is due to the procedure, or is it intra-alveolar hemorrhage? Again, it's a question of semantics to find out what it is. And how do you find it out? Dilated lymphatics due to the procedure, or are they really dilated? Is it hyperinflation or emphysema? Where is the gray? It's a gray zone. Even the talc powder, is it from the glove or the person has inhaled? Diagnosis is different. Or add to that your air drying and fragmentation and your formalin pigments, especially in your postmortem specimens. Your slide is, your pulmonary pathology slide is something to look at. So that is the crush artifact in the squamous epithelium. It may look dysplastic. The crush in the small cell aids you in the diagnosis. Can anyone tell me which is true and which is false? Which is obvious, no? Very easy, no? This is only in some part, and some part there is some other pathology. So this is pathological. This is created by the surgeon. It's a guesswork only, see? There is only one picture, not two. So you have to say whether it is hyperinflation or emphysema. Why? Why emphysema? Emphysema, only one type of emphysema affects part of the thing. The rest of the emphysemas are involve all of them. Here it is only part is involved. You see, this part only. This part is okay, no? So it's an artificial pulling, sort of hyperinflation it is. It's a talc powder. Actually, I put the talc powder to take the photograph. This is for cytologists. The normal cells will look abnormal and the abnormal cells will look normal with drying. And this, all PGs will see, what is this? All the RBCs are looking like this. This is our formalin pigment, favorite thing in your postmortem staining. So you find any postmortem slide, you will find this pigment. Other confusions beyond this artifacts include reactive atypia, Crayola bodies, goblet cell hyperplasia, and your anthracosis, which is not there in any other organ. It will mask everything. You cannot bleach this pigment. With this melanin we can bleach, so you have to look under it. As sir was saying, we have to look some other methods to see under the microscope. I have seen undergraduate students looking under the microscope to look at whether it is round or square to identify. It can't be like that. Then radiation-induced changes. Let's see some of these. This is the atypia taken from the cover of a book. This is the Crayola body. These bodies, they are desquamated cells which look very hyperchromatic, mimicking what you call malignancy. They are not. And here is when it's full of pigment, you don't see anything, no cells see. This is not hyperplasia. This is a tumor, is it? No, it's not a tumor, it is a hyperplasia. If somebody takes a core biopsy of that, you will say it is solitary fibrous tumor. And you see this multinucleation, bizarre artifacts, and asthma shows this thickened basement membrane, you see. So somebody may find it out and think it's abnormal. It's not. Look at all the mucin there. To top that, we have the osseous metaplasias, the megakaryocytes and whatnot. So here is a tissue which is really confusing. Its histology is difficult to understand because it varies from place to place in the lung. Its artifacts are there, and there are lots of confusing entities which you have to be aware of. Once you have learned this, you can learn your pulmonary pathology. Now from here, straight into the last part. What has WHO done yesterday? So that is in one slide I have finished. Thankfully, there are only few changes here. I will show one slide for each, so we will just skip this. This SMARCA4 deficient undifferentiated tumor. Now they say it's a poorly differentiated carcinoma. We also report it as a poorly differentiated carcinoma because we don't know how to do this SMARCA4. Bronchiolar adenoma. See, this is a new entity WHO has described. Because we always think these polypoidal adenomas are in the bronchus only. It can come deep in the bronchioles and sometimes even within alveoli. When it occurs there, they call this tumor. So you may think it is actually malignancy. It is not. It's a benign adenoma. And they have removed the like from lymphoepithelioma like carcinoma. Because they say it is a lymphoepithelial carcinoma. Why put the like? So WHO doesn't like to remove anything, no? So they added the like into this. Enteric like adenocarcinoma, type adenocarcinoma. From enteric adenocarcinoma, it became enteric type adenocarcinoma. They never throw out anything. They will only add newer and newer entities. The book will become bigger. Post-graduation will become tougher. But this is not a new thing. They found out that adenocarcinoma in situ, they pushed it to minimally invasive because they found it's bigger, it can grow bigger and bigger and bigger. And in situ means you should have a definite, some basement membrane, something. When are you going to call it malignant? So they said they redefined it as minimally invasive. There is nothing like in situ. You have a hyperplasia, atypical adenomatous hyperplasia. There is nothing in between. Now this micropapillary pattern, WHO has said now that it is quite important to mention. There are only two patterns in adenocarcinoma you need to mention. One is solid and one is this micropapillary, because both are highly aggressive. They will have to add more regimen. So this micropapillary pattern, what is micropapillary is very simple. It doesn't have, it's papillary but does not have a core. But first year PG you can fool, because we teach that papillary means fibrovascular core, and then we say micropapillary means no fibrovascular core. Confusing, no? But that is the truth. So this is micropapillary. Whether you understand it or not, it doesn't have a fibrovascular core but looks papillary. And you have to do all these things, because when micropapillary comes, you don't know whether it's a Mets or not. Calretin negative, CK7 positive, 20 negative, and Chi67 is somewhat in between. TTF1 positive, so thankfully it's an adenocarcinoma. It's a metastasis into pleura from adenocarcinoma lung. So remember that high grade solid micropapillary histologic type subtyping has to be done. So these are the small changes which I identified in the WHO. Now let's see the ISC in lung pathology. So we started with the basic panel like TTF1, CK7, 20, 63 and 40, napsine, 5, 6 and synaptophysin. I'll tell you my experience on that, which is quite confusing. Chromogranin, all these, KE1, A3, KE6. I think this is enough. If metastasis is there, you suspect, you have to add the other panels for the metastasis like CK19 for the pancreas, PSA for this thing, GATA3, everything. You know all these things, I know. And for mesothelioma, you do a triple thing, calretinine, podoplanin and CK5/6. I always find that some squamous cell carcinomas are negative for both P63 and P40. I suspected they were squamous carcinomas initially. Later I found that there are real squamous cell carcinomas, histologically squamous cell carcinomas, which are negative for this. Then I understood that the negative IHC does not rule out over a morphology. Morphology always remains at the top. The positive IHC is always good. Both squamous and adenocarcinoma can be positive for EGFR, that probably you know. And EGFR and ALK are mutually exclusive. Can anybody tell me what's mutually exclusive? You toss a coin, it's either heads or tails. So a tumor can be either EGFR or ALK. A coin cannot stand like that. Only in films it will happen. This is another thing I want to share. I will show you the cases. CK20 may show aberrant expression. Lung adenocarcinoma, primary lung adenoma. The patient has no secondaries. So seeing CK20 alone, don't jump into the conclusion that's a myth. Of course, mucin should be done for all. And if all markers are negative and CK is positive, pan CK is positive, you think of a undifferentiated large cell carcinoma of the lung. And I have found that synaptophysin is better than chromogranin. Somehow I find chromogranin is less sensitive, maybe more specific, maybe. Similarly, P63 is a better screening one than P40. Like government colleges, no, we all, how much minimum money you can get from the patient. So to do P63 or P40, both we cannot do. So in such situations, these are my impressions, because we have to be very stingy about the use of ISC to get to the truth in the shortest way possible. And there is a small cell variant of squamous cell carcinoma which can be easily mistaken as a small cell carcinoma. This is not that uncommon. And of course, you have to think of this salivary gland tumors confusing. Let's see some of these. See, this is classical CK7 TTF1 positive, but these can be negative for napsin. Napsin is somehow I don't find, sir, you will have to share your experience. I don't find that much useful. And ISC in small cell carcinoma, of course, is a must, and often it will be TTF1 negative, 50-50 it is. Your hit is P63, if it looks like this, I call it chanagam, meaning cow dung. I don't give any value to this. Sometimes it will come like that. And P40 is negative, 20 negative. So synaptophysin gives you the answer. And IHC in scanty tissue is pretty good. Sometimes this is all what the clinician gives you. 1 or 2 tumor cells here and there. I am sure all of you would have come to this. And they won't do a rebiopsy. If they say patient is bad, he has got pleural effusion, he is breathing his last air in, now we want the result. Sir, I have put it for ISC, so he said I will order the coffin, because by the time your result comes, it is going to go. So you find this, there are malignant cells, good, but we want to know their nature. So here is our IHC magic. TTF1 positive, CK7 positive, P63 negative, calcitonin negative, you can give a diagnosis. So with very little tissue, you can give a diagnosis. That's there I say IHC is pretty good. Now the molecular targeted therapy, we have to do 3 at least. EGFR, ALK and ROS1. The other 5, BRAF, VEGF, CRAS, RET, MET are still under trial. The immunological are still under further trial, PD1 and PDL1. So altogether you can do about 10 chromosomal things for targeted. But widely used are EGFR, ALK and ROS1. They are all good and easy to do IHC, and of course you can confirm with FISH if it is equivocal. Now the predictive marker, what's going to happen to pathology we were just discussing. Pathology will give a liquid biopsy where they will extract the DNA from the tumors which are spreading into the blood. So here is the problem. The problem is the liquid biopsies can be evaluated if the circulating DNA is adequate, which will only be there dependent on the tumor burden. If it is a low tumor burden, liquid biopsy is finished. You have to do the other biopsy. And be cautious diagnosing pre-neoplastic condition. I am not very sure. I have seen this atypical adenomatous hyperplasia adjacent to the, it is like that atypical nodular hyperplasia in prostate. I still feel mystified, is it real? It's a way to escape for, you want a repeat biopsy that you give that diagnosis rather than something which is truly defined. But atypical adenomatous hyperplasia is better defined. You will see that around adenocarcinoma. And dipnet you can see around the endocrine tumors. Carcinoma in situ also you can see. So in pre-neoplastic lesions, unlike in other places, in lung you can identify. You have to be careful to take more bits. Certain other things about lung cancer is, lung cancers can be synchronous. Like you can have an adenocarcinoma and squamous cell carcinoma. We have a case, I will show you that. And the same lung may show two different tumors. And just synoptic reporting is a big thing now. So you have to have three synoptic reports, one for lobectomy, one for small biopsy, and one for the pneumonectomy. And which protocol you follow? CAP or RCPAT or that Australian thing? So Kerala chapter we have done a very good thing in the sense that 6 of us in each group, we have worked out 64 synoptic formats. After looking into all this and discussing with clinicians, one page, single page, Indian type, what we can actually do. So that will come out very soon. We are making the software and we will share with everybody. We have done that work because it's huge running into pages. Which typist? You have to have 10 typists to type that. Or our PGs will become typists later on. Now they are painters, they will become typists also. So cutting and bitting, you can do that. That is also a job. Painting is another job. Like that, typing is another job. PGs complain, sir, pathology is topology. I have to go on searching everything. Search. So you are a topologist. You are multi-talented. Multitask you can do. Sorry to digress. And so this synoptic reporting, three things are important. You have to cut under the bronchus and the two pleuras, the medial channel and the visceral pleura. Don't forget to say how much distance that millimeter that tumor is. You may miss in 1 or 2, exactly in that fellow will ask. See, you have not mentioned the clearance. Sir, it is far away, 1 kilometer away. No problem. I want to know exactly. So don't miss out on that. And this lymph node, you have to verify whether it is this side or that side. Now they are doing EBUS, but they won't label. So coming to EBUS, this EBUS TBNA ROS combination is going to come into lung pathology. You do an EABS, you get the very little material and check on-site evaluations of pathologists right into the theatre now. That's going to come very, very fast. So we are not going to become extinct, we are going to become part of the theatre team. Don't worry about that. And now the last part, I kept it the last part because medical lung disease is as confusing to me as you. So these are some of the snippets which I have. So the medical lung disease is either interstitial pneumonia or other infective pneumonia. That is medical lung disease basically. Now the infective pneumonias, whenever you see these bacterial pneumonias, look for this Legionella and actinomycosis. Take more sections and see. Don't miss that because their treatment is different. And viral pneumonias we don't see at all in histology, but if you do BAL in pneumonias,
Shankar sir to give the memento to Dr. K. Krishnamurthy sir. To give the memento to Dr. Untitled ma'am. Maybe Lakshmi ma'am.